I'm going to talk today. Jens had asked me, and uh, Udi had asked me to talk a little bit about MIS surgery. And can you guys see this okay?
Yeah, we can see it.
Okay, perfect. And my sort of evolution I started doing a lot of MIS surgery as soon as I finished residency and really became a huge fan of doing MIS surgery. These are my disclosures. And really, when you start looking at MIS surgery, for me, the workhorse, especially if you're going to do tumor oncology work, is I think you have to understand the spine in a three-dimensional sort of structure. And initially, the coolest thing was to put in percutaneous screws and again, at the time, I was finishing residency, there was a couple of systems, but there wasn't really any systems that were for more than two or three segments. And then, we were doing these huge, what I would call shark bite incisions, because most of the time, when you do tumors, it involves the vertebral body, as Dr. Chapman just demonstrated, and all the exposures were really morbid. They were long, lots of blood loss, high infection rate. And so I really got interested in doing lateral. But again, at the time, there wasn't a lot out there, and people didn't really didn't understand, the approach, and everything was kind of new, the retractors, the instrumentation. And again, you have to look at when you do lateral, you really have to understand where these structures are, the psoas, the retroperitoneum, even the lumbar plexus, and the relationship of the peritoneum to the diaphragm. I mean, all these things, when we're residents in neurosurgery, I remember the only time I ever got into the retroperitoneum was when I did a shunt, and you could see the distal tip of the shunt had coiled into the retroperitoneal space. It's just not an area that we're trained in. It's an area that urologists really know well, but for neurosurgeons and spine surgeons, we really don't understand it. And it wasn't really until I got to Seattle and we spent a lot of time in the lab that I really started to, and a lot of this work was done at the Seattle Science Foundation. And again, all the old textbooks, you can see they kind of have this, cartoon-like picture of the plexus, but that's not what it really looks like. And the plexus is really embedded in the psoas muscle, and it's very challenging anatomy. And again, these are, it's kind of like the brachial plexus, in the arm. We memorize the trunks and the branches and the anterior, posterior divisions. But all of these are, for med school, you kind of these get ingrained in your head, but then, real practice, you don't actually, this is not what it looks like. And again, this is a beautiful 3D reconstruction that one of our fellows did in the lab, and reconstructed it. And again, genetics does play a huge role in this. And you can see here, this is Dr. Chapman and his cousin, and you can see there's some similarities in their facial appearances, but personality-wise, they're very different. And the same goes for lumbar plexus. We found out, that each person, male, female, I mean, everyone has a different, the anatomy is totally different. And we did lots of cadaver work. These are some we put some nitinol wires and basically traced it out. And this is what the plexus looks like on a lateral in a cadaver. And again, this is a figure that we made for one of our books, but this is actually, the plexus is embedded in the psoas muscle. And it's very difficult unless you take the psoas away. This is what it looks like when you subtract the psoas. It's a really complex set of connections. If you're doing lateral, you're putting, you dilate, and then we this was another study that we did in the lab just to show the relationship of the disc space to the different branches of the plexus. This is a beautiful, I think this is one from one of Zia's papers that just shows, the complex anatomy, especially from a lateral approach. And you can see the kidney there and the vasculature and the retroperitoneum has kind of been dissected away. And this is another beautiful illustration of one of our fellows took a cadaver, and this is a 3D reconstruction of the nerves. And you can see the yellow and how complex these interconnections are. And so, when you do a lateral approach or you do an MIS approach, you really have to understand these relationships. And again, even when you're going, this is a picture of the thoracic spine. You can see the rib cage there, and the retroperitoneum's been kind of peeled away. You really have to have a really good understanding of these different anatomic relationships and where the diaphragm is. This is another excellent dissection to show you. These are the disc spaces that where I was showing you previously, and this is a dilator. This is of a tumor case that I did, and you can see you cannot. It's not like you can't retract on the plexus or try to move it. There's a lot of the structures of the plexus, you can see it's basically embedded in the psoas. So you have to understand, this is how the femoral nerve and a lot of the different branches, they're kind of fixed. You can't really move. And so you have to adjust, you have to be able to adjust and move the retractor. And neuromonitoring is a big part of doing lateral surgery. And again, these relationships, you can see the L3-4, L2-3. The lower you get down in the lumbar spine, the higher the risk there is. You can see there's the femoral nerve at L4-5. You can see you're just anterior to it. And this is actually how, when you're doing a lateral corpectomy, you can see where usually what I do is I dock on the disc below and then go to the disc above. I do a full discectomy, then do the corpectomy. But you have to really understand these relationships. And then you can see here, you can see like at the 045 level on this beautiful 3D reconstruction that one of our fellows did, you can see how close the femoral nerve and all the nerves are. So if you're going to do a corpectomy, and this is with the psoas gone on one side, and then the other side, you can see the psoas is there. Neuromonitoring is a really important part of doing it. And again, in multiple studies that we have published, you really have to study the preoperative imaging. And I always sort of preach, start just doing basically one level interbody fusions. Don't start doing a L4 corpectomy as your first case. And I always tell, the fellows and people doing lateral surgery is that you want to identify and find. So if you're doing L4-5 and you want to find the femoral nerve, you want to be able to map it out, and that's an important part of doing the surgery. And again, whether it's a tumor case or trauma cases, this approach can be utilized. This is a patient who had a tumor, thoracolumbar junction. You can see again, pretty significant retropulsion. So you're not going to be able to get away by just doing a posterior only here. What if, again, this is an older patient, a lot of comorbidities. What if you could do this in 2 stages? And what if you could do an MIS approach? And that's what we did. We went from the back and then we went from the front and stabilized the patient from the front. And again, there's another patient who had a cancer diagnosis, had a kyphoplasty that failed, and then had a posterior fusion and that failed. And you can see, you just like trauma, tumor cases, you have to understand the biomechanics, and you have to understand, the anterior column provides a significant amount of load sharing. We went in, took out the posterior hardware, did a lateral corpectomy and placed a lateral plate, and then I think I probably waited 3 months, and then went in and did a posterior MIS fixation. Here's another tumor case that was done. Again, you can see this is the L4 vertebral body. And I did it just, this is just an intraoperative view showing, the placement of the retractor and then going in and doing a corpectomy. And you can see you can put a really very large implant in. And again, just as was demonstrated just in the lab here, these devices have really, uh, you know, significantly changed the game in terms of, you can basically start with like a 22 or 20 millimeter height and expand up to 40. And you can see here, I've got a retractor in there, and you can see I've got an osteotome and a cob that I can go all the way across the disc space and get a very good resection. And again, this is one of Dr. Chapman's cases. You can see the very large exposure that he had to do in order to get access. And this is my exposure. You can see I think I used a little tiny incision. So you can see the difference between the exposures. And I think, between the two incisions, I probably would choose a smaller one. And you can see how tiny of a retractor that is that we placed. And again, the retractor placement is key. So this is a lateral of a corpectomy that I did, and you can see you can go all the way posteriorly. You can see the dura. And a lot of times I actually will bring in the microscope and go all the way back. You can drill the pedicle, you can see the neural frame, and you can go all the way posteriorly and take off that, get a good margin and a good resection. Here's another case that we did. I think this is a case that Jens and I did. He went in posteriorly. That's what we do a lot of times. He'll go in posteriorly, do a very nice separation surgery, and then I'll go in and basically we'll stage it, probably separate by a couple days, and then I'll go in and go in from a lateral. And this way we're able to minimize the number of levels that we place posterior fixation. This is another case, another L3 tumor. You can see here it's got pretty significant collapse and as well as retropulsion. And we did the same thing. Dr. Chapman went in, and a lot of times we'll actually put a tiny screw on one side, usually on the right side, and then we'll go one above and one below. Again, as discussed earlier, you really have to look at the tumor biology, the comorbidities of the patient, and then what you're trying to achieve here. And each patient is different. But for someone like this, where they've got significant comorbidities and you just want to go in and stabilize and take as much of the tumor and then follow up with radiation, I think, doing a minimally invasive lateral approach has really been a game changer for me in my practice. Here's another case that Dr. Chapman and I did. Again, he went in posteriorly. And then this is another case I wanted to show you guys how posterior. You can see that retractor. You can see the dura all the way from the top of the retractor down below. And then I start posteriorly and then I work my way anteriorly. This is what the final construct looked like. And again, sometimes in these cases, this patient had metastatic disease. We'll get as much as we can and then follow up with radiation. Usually, again, depending on the tumor biology in the case, usually it's at least 6 weeks. Sometimes it's 3 months, especially with a big reconstruction like this. Here's another case that we did. Again, you can see there's the main level here is L4. And again, at L4, you really have to be careful of the lumbar plexus. Retraction time is a big deal. And so we staged this one. And again, posteriorly, we went in posteriorly, and then I came in anteriorly several days later. This actually was a very young patient who we did. And again, most people would say, you can't do a corpectomy at L4 because of the plexus, but in my experience, you can. In fact, in our series, I don't think there's a case where we aborted or couldn't do L4. You just have to find the femoral nerve and go anterior to it. And here's another case that I did recently, and this one actually was done all posteriorly. And again, because the devices and the cages and all the different instruments that we have gotten so good. I wasn't actually planning on doing this one posteriorly, but we got such an excellent, even on the table, the tumor just came right out, and then we got basically entire vertebral body came out. And unfortunately, this patient had widely metastatic disease, and also had tumor in her pelvis. And so we didn't want to do anything heroic. We just wanted to kind of stabilize that one area. And this is the MRI on that same patient. She was pretty miserable, just in terms of her compression there. And then she actually got worse. And so this is what we ended up doing for her. And it was done all posteriorly. And you can see, again, we used fenestrated screws and an expandable cage. She did excellent. And here's her, films. I think 6 months post-op, you can see there she's got pretty good, still got good correction, no subsidence. And she got radiation afterwards. So, you don't have to always go lateral. You can also go posterior. And again, even in the low lumbar spine, these expandable cages, you can kind of rotate them, you can bring them in. So this field is continuing to get better and better. Here's another case actually that shows, I wanted to show specifically the low lumbar spine. Here's a patient with a tumor. Again, did this. We staged it. We went posterior first and then went lateral. Here's another case that we did. Again, here's the MRI. You can see here, it's basically one vertebral body, and there's some posterior compression, but mostly it's anterior column. Here's the intraoperative images, and this patient, I believe, was embolized. And again, a lot of these cases now, I will do one above, one below. Be able to use cement and fenestrated screws has been very important in these cases, because most of the time their bone quality is not very good. And so if you're going to do a short segment fixation, the risk of fracture is pretty high. So, a lot of times we'll use cement, and that really helps in terms of, trying to get especially if you have poor bone quality. Here's another case that we did laterally. This was an L3 tumor. And again, you can see, I wanted to show this intraoperative view of that's our stimulator. So we're finding the plexus, mapping it out. And then I basically, on all these cases, I will put the retractor, if you guys can see that retractor, that's an intraoperative retractor. You can see how you can, as long as you find the lumbar plexus and you map the nerves, I try to put the retractor right next to the nerve. And you can see what a large, from a small incision, you can get pretty significant access to the vertebral body and get a very good resection. Here's that same case. You can see the vertebral body, both posteriorly, anteriorly, is all gone. And there's the implant. And we try to put allograft inside the cage and around the cage to get this to fuse, because what we found is that and we talked about this earlier, getting cancer patients to fuse is very challenging, and there's a very high pseudoarthrosis rate. So we try to pack as much allograft as we can around the cage and in the cage. Here's another case. This was actually a revision. So doing this lateral approach has allowed us to do a lot of these revisions. This is a case Dr. Chapman and I did where the patient had retropulsion, had very scarred down anatomy, very difficult to do this, and they actually had previously had a shark bite incision, and we went in and went the shark bite incision is actually ironically usually go very anterior. So by doing this lateral approach, you can go posterior, you can go into the retroperitoneum. You don't have to take the diaphragm down. And basically, we went in, and here's some intraoperative views. I actually used a metal cutting Midas, cut the cage in half, and you can see that the two halves there that we took out. And then I was very careful about placement of the cage. You can see that there was pretty significant subsidence of the vertebral bodies before, and we didn't want to do a corpectomy. And so when I placed the cage, you can see there's that divot below, and I was very careful. I tried to put the cage as posteriorly as I could, and try to get good end plate contact. And this patient did very well. Again, very tiny incision compared to the incision the patient had done before, and had very little blood loss as well. And again, this is a plug for the fellows and all the work that we did over the last 15 years. We actually ended up publishing a book about the plexus and all of our lateral approaches. And so, for me, this approach and doing MIS surgery has really been a game changer, both for my patients and my practice. And I really appreciate being involved in this course, and I look forward to participating in this next year. Thank you so much.
That was amazing. Absolutely amazing. Quick question. Are you using titanium cages, and is there any opportunity to peak anterior, or is that just not feasible?
That's a great question, Mark. And actually, the companies now, they do have very good peak cages. And so I'm using more and more peak. And that it's definitely, it's got a ways to go, but it's gotten a lot better. So, and I think, in the next few years, I think that's probably what, it's like the pendulum is swinging back towards peak, especially for cancer stuff. So,
I mean,
I want to support Mark. I want to hear your thoughts, Mark, because of course we want to have peak, but I too have struggled with the lack of interface control of a peak device relative to our metallic handling stools. I don't know what your technical pointers are. This is what I liked about this device, and I have no conflict of interest relative to the supporting manufacturer there, but that carbon fiber had a really positive interface. It's just like a normal metal cage.
We, from the back for METs, we use almost exclusively cement because it's so easy to, put in as an open vertebroplasty, and that's worked pretty well in our hands. When we do corpectomy from the back and it's complete and we need a cage, I've only used static P carbon fiber, and that's worked fine. But I've done it mostly in kids and children, for neuroblastoma and such. So I don't have a huge experience in adults putting it in, and certainly not with a lateral approach. But it is beautiful.
Just for the record, I don't do any far lateral surgeries because I'm working next to the master, who's currently on injured reserve, and he looks great. And so whenever there's something anteriorly, I just basically try to do as good as I can posteriorly and do a temporary posterior decompression, then get the master to do a fill in from anterior. So shall we move on? Dr. Lewis Kolb.